Hello, my name is Sam Lam, and the title of the lecture is Bedside Ultrasound Diagnosis of Pediatric Intussusception. And here are the objectives of the lecture. So what are some of the good reasons to learn how to diagnose pediatric intussusception on bedside ultrasound? Let me illustrate this with a couple of case scenarios. First, you have an 8-month-old female who was brought in for 2 days history of diarrhea. During the interview, it was brought up that the child has had intermittent episodes of high-pitched screaming when she looked really uncomfortable. Her exam is all normal, including a guaiac-negative rectal exam. Your astute resident brings up the possibility of intussusception, but your clinical suspicion is not really high given the history mentioned. Now you're just looking for a quick way to end this visit, and bedside ultrasound is your answer there. In the second case, you have a 10-month-old male who was brought in for intermittent vomiting or lethargy. There's no mass or focal tenderness on abdominal exam. Though these are not the classic textbook presentations, you have a moderate clinical suspicion for intussusception and order an ultrasound. There is an adult ultrasound technician in-house, but she is backed up with cases from the rest of the emergency department. The pediatric radiology attending has to be called in from home if intussusception is found and a barium enema is needed. In this case, performance of a bedside ultrasound for intussusception would help facilitate the disposition of the patient. Just a quick review of some of the key facts of intussusceptions here. Intussusception is defined as the invagination or telescoping of one loop of bowel into another, dragging along its associated mesenteries. The inside bowel segment is called the intussusceptum, while the outside bowel segment is known as the intussuscipiens. Unlike adult intussusceptions, the majority of pediatric intussusceptions have no obvious lead points, and 90% of them are ileocolic. The classic triad we learned about pediatric intussusception, namely episodic colicky abdominal pain, right lower quadrant mass, and guaiac-positive current jelly stool, it's actually present in less than 30% of proven cases of pediatric intussusception. More commonly, children with intussusception present with nonspecific symptoms such as abdominal pain, vomiting, and irritability. Alternatively, they might present with lethargy. Therefore, bedside ultrasound can be a very useful screening tool in pediatric patients concerning for intussusception. The preferred ultrasound probe used to diagnose pediatric intussusception is a high-frequency probe in a range of 5 to 10 megahertz, because most of the anatomical structures we're interested in are rather shallow. In most cases, this would mean using the ultrasound probe with a flat footprint on the machine. In order to visualize pediatric intussusception, graded compression technique should be used. In other words, slow and steady pressure should be applied via the ultrasound probe onto the abdominal wall in order to displace the overlying bowel gas. The abdominal cavity should be scanned in a systematic way in order to look for evidence of intussusception. A common approach, which is also my approach, is to follow the pathway of the colon in a 3/4 of a circle fashion, since this is where intussusception is most likely to occur. A more comprehensive approach would be to scan in a so-called mowing the lawn fashion in order to cover the entire abdominal cavity. What we're looking for in ultrasound is what is known as a donut or target sign. Essentially, you're looking for a complex mass with alternate concentric hypoechoic and hyperechoic layers corresponding to layers of invaginated bowels in a cross-section. And recognizing this image pattern is the key to making diagnosis of intussusception and ultrasound. If you gotta remember one image from this lecture, this is the one you want to burn into the back of your minds, and this would help you greatly in diagnosing intussusception on ultrasound. In this case, the inner concentric circle corresponds to the intussusceptum, while the outer concentric circle here corresponds to the intussuscipiens. The hypoechoic area in between corresponds to the mesentery, as well as the edematous bowel wall. If you catch an intussusception on an oblique plane, it can sort of look like a kidney in an ultrasound, hence the name pseudokidney sign. Once again, the inner concentric circle represents the intussusceptum, and the outer concentric circle corresponds to the intussuscipiens. In the longitudinal view, once again, you can see layers of invaginated bowel with the intussusceptum on the inside and the intussuscipiens on the outside. This is a clip of another intussusception caught in a transverse or short axis view, as well as a longitudinal or long axis view. In the radiology literature, ultrasound has been found to be 95 to 100% sensitive and 88 to 100% specific for diagnosis of intussusception in the pediatric population. In one of the studies, junior radiology residents with limited training performed as well as senior residents and attendings in identifying intussusception in the pediatric population. There have been case reports and review articles published on emergency bedside ultrasound diagnosis of intussusception in pediatric population. However, so far, there has not been any clinical trial on the accuracy of emergency physician performed bedside ultrasound in diagnosis intussusception in children. So what are some of the pitfalls in diagnosing pediatric intussusception using bedside ultrasound? Because ultrasound by its nature is operator dependent, false positive and false negatives tend to be a little higher in the hands of an inexperienced operator. Common false positives can be due to the presence of stool, inflammatory bowel disease, enterocolitis, bowel wall hematoma, and psoas muscle. Overlying bowel gas can obscure the view of potential pathology and create a false negative bedside study. Here's an example of stool in the colon, which can be easily mistaken for intussusception on bedside ultrasound. Notice that despite the presence of echogenic structure within the colon, we don't see any layered and concentric bowel loops within the colon, typical of intussusception on ultrasound. And once again, seeing a concentric layer pattern is the key to making diagnosis of intussusception on ultrasound. Once the operator becomes comfortable using ultrasound to diagnose pediatric intussusception, it can be used as a screening examination in patients with low to moderate clinical suspicion for intussusception. And this is especially valuable in emergency departments without 24/7 ultrasound technician coverage. The following is a suggested algorithm in the use of bedside ultrasound for diagnosis of suspected pediatric intussusception. In patients with low to moderate clinical suspicion for intussusception, it is probably reasonable to use bedside ultrasound to risk stratify them into those that are highly likely or highly unlikely to have the disease and manage accordingly. On the other hand, if there's high clinical suspicion for intussusception, bedside ultrasound can be performed if there's minimal delay of care. Definitive management, such as barium or enema, and surgical consult should be sought as soon as possible. Needless to say, the operator has to have a reasonable level of confidence in his or her bedside ultrasound skills in order to apply the algorithm. Going back to the cases at the beginning, in the first case, we had low clinical suspicion and a negative bedside ultrasound will allow us to comfortably rule out intussusception and send the patient home. In the second case, we had a moderate clinical suspicion for intussusception. A positive bedside ultrasound will allow us to expedite the care of the patient by putting in a timely call to the pediatric radiologist for definitive care. A negative bedside ultrasound in this case would prompt us to look for alternative diagnoses in this patient. In summary, ultrasound is highly sensitive and specific in diagnosing pediatric intussusception and can be performed fairly easily at the bedside. A high-frequency probe is recommended in order to visualize the relevant anatomy, along with graded compression technique and a systematic approach in scanning the abdominal cavity. In scanning for intussusception, one should look for the donut or target sign, the pseudo-kidney sign, as well as closely stacked layers of bowel in the abdominal cavity in the transverse, oblique, and longitudinal views. This concludes the lecture, but please feel free to contact me for any questions. Thank you.